Here we go. So if someone's typing, and if you can just put yourself on mute while you're typing, and we'll get started. Well, good morning or good afternoon to everyone, depending on where you are. This is Joy Burkhardt with 2020 Mom, and we're thrilled to be presenting the last in our Innovation Award webinar series, the Innovative Programs in Care Honorable Mention, Park Nicollet, for their Women's Mental Health Reproductive Program. We'll introduce Dr. Mauren in just a moment here, and first, we want to start by thanking our funder, the Zoma Foundation, for making this Innovation Award program possible. For those of you who haven't been with us yet, you're welcome and invited to join us and look at the website, 2020mom.org, to find out who the other Innovation Award program winners were, and also find materials about those programs as well as recordings to past Innovation Award webinars. Before we jump in and introduce our guest speaker today, we do want to ask who's on the line, and it looks like there's just a handful of you on right now, and we suspect that number will start to increase throughout today's webinar. So I'm going to ask if you could use the GoToWebinar control panel. It's usually on the right-hand side of your screen. There's a question feature in that GoToWebinar control panel. If you don't see that control panel, try toggling because it may be behind a screen. And I'd like you to go ahead and use that question feature. And instead of asking a question, tell us who you are. We'd love your name, where you're located, if you are a practicing provider or a survivor of a maternal mental health disorder. Just tell us a little bit about who you are and why you're here today. So go ahead and use that question feature in the GoToWebinar control panel and let us know that you're on. And I see we've got Hannah, Zoe, Carol, Elise, Amanda, and it looks like a couple others are joining us. So if you wouldn't mind, we'd love to know where you're located. Again, you can use that question feature. If you see a chat feature and prefer to use that, you can try that too. Usually the question feature works well. And I don't see that anyone's been brave enough to introduce themselves, so we encourage you to do that when you feel comfortable, and we'll circle back and let folks know who's on the line. All right, great. Let's go ahead and get started. I'm thrilled to introduce Dr. and Gabe. I'm wanting you to remind me, is your last name pronounced Mauren? I'm embarrassed. I'm thinking,
no, that's okay.
I'm pronouncing your name right.
Nope. My name gets pronounced lots of different ways. It's actually Mauren.
Mauren, that's right. I know
Yeah.
I was doing something wrong. Great. It's such a pleasure to have you on today. You can see that there's a picture of both Dr. Mauren and I on the line. I want to just quickly introduce Dr. Mauren to everyone. She is a psychologist and the clinical manager for the adult psychotherapy practice at Park Nicollet Health Services. We'll hear more about the program in just a moment. It's located in the Twin Cities, Minnesota. She's earned her master's and PhD in counseling from the University of Minnesota. She completed her pre-doctoral internship and postdoctoral fellowship at the University of Pennsylvania. She has worked in higher education and community mental health with patients from multicultural backgrounds, struggling with a variety of mental and physical health concerns. Dr., and I'm going to say it wrong again, not Mauren, you just told us.
No, you're right, Mauren, yep.
Mauren, good. It's one of those names you have to say a few times to get right. Dr. Mauren has a clinical specialty in perinatal mood and anxiety disorders and is the clinical lead for Park Nicollet's nationally recognized and award-winning, we can say, Women's Reproductive Mental Health Program. And so
Yes.
we're so glad that you're with us.
I'm happy to be here.
Welcome. Yeah, and I get to say, for those of you who were able to watch the webcast of the 2020 Mom Maternal Mental Health Forum last month, that we had Dr. Mauren on one of the panels, and it's just really great to see your face up on the slide again, and great to see you and hear your voice.
Yeah, great.
Welcome
Thank you
back.
again for having me. Yeah.
Absolutely, absolutely. Good. So we're really thrilled to get to share your program with a wider audience. And I do want to just pause for a moment because there are a couple people that did introduce themselves, and I want to just introduce them quickly. Thank you. Carol from Ojai, California is with us. Zoe in Bend, Oregon. Hi, Zoe. We're glad you're with us. And Zoe works in community mental health as well, as a maternal mental health case manager. And let's see, Carol is a child and family consultant in, let's see, well, Carol, you might have said where you're from, but it's not popping up for me. So thank you to the three of you for letting us know you're on and why you're interested today. We know quite a few others will watch the recording later, so welcome to all of you that are watching the recording. We're going to jump right in, and I'm going to advance to the next slide. You'll see the slide up right now. It includes Dr. Mauren's email, my emails here as well. Don't be shy about using them. We're going to have the email addresses up at the end of today's webinar as well. But I'm thrilled to have Dr. Mauren with us today. And we're going to start by asking if you wouldn't mind sharing a little bit about Park Nicollet. Tell us about the healthcare system / health plan, right, as we've had a chance to learn about. And also where you're based, what you do. It's a huge system.
Yeah, we are. We are a really big system. So on that slide, you can see that we have over 8,000 employees on just the Park Nicollet side. So we're sort of situated as an interesting health system here where within one big sort of mothership umbrella of something called Health Partners, there are actually three divisions within Health Partners. So there's the Park Nicollet Health Services, which is clinical and care delivery. There's also a Health Partners medical group, so that's Health Partners Care Delivery. And then we have a third arm where we have our own commercial and state health plan. So across that big, huge organization, I believe we have about 25,000 employees. So that's pretty big. My side is the Park Nicollet side. I know that best. So we are big. We have sort of a main campus here in St. Louis Park, Minnesota, which is up there. And that campus includes our biggest hospital and then kind of every primary and specialty care department you could possibly want, all in one place. And then we also have across the sort of Twin Cities and metropolitan area, primarily on the west, northwest, and sort of southern part of Minneapolis and St. Paul, we have lots of smaller clinics or medium-sized clinics where they will have, a combination of primary and specialty care. So we're spread out all over. I know between the whole organization, so between both care delivery branches, we serve about 1.8 million patients, which is about a third of the state of Minnesota. So we're pretty big.
Wow. That is really good.
I know, right? Yeah.
Can you tell us a little bit more about, and obviously a lot of deliveries in your hospitals here, 6,000 deliveries to a lot of births. But tell us a little bit more about the part of Minnesota that you serve. And I don't know if others often hear this too, but, I'm located here in California, but it does feel like Minnesota pops up often as sort of this hub of health innovation and wellness. Like, do I feel like Minnesota and Twin Cities pops up as like the healthiest city in the nation or a great place to live? It's cold. Tell us more about
things like that. Yeah. So if you're looking at a map of Minnesota, Minneapolis, St. Paul, those Twin Cities, and then the surrounding suburbs were sort of in the bottom, half of the state. And then kind of everything else it's much more rural. So we have a very large urban center and then a huge sort of rural and, traditional, it was, northern Minnesota was mining, southern Minnesota was farming. If you've heard of the Mayo Clinic is in southern Minnesota, so there's another kind of a smaller urban portion there in Rochester, Minnesota with that. But you're right, we typically make a lot of those lists for, the healthiest, most access to healthcare, the best bike paths. Our population also tends to be very highly educated. We will, be on those kind of lists as well. The population that we serve here, if I'm speaking primarily in the Twin Cities, is sort of an interesting one because certainly we're in Minnesota. We are primarily a, Eastern European descent population. There's a lot of Caucasian people here. But we also have a very interesting immigration pattern that's happened sort of for us since the 70s. So we have a couple large groups. So we had, after Vietnam, the Laotian and Hmong people immigrated to Minnesota. So we have a huge Hmong population. More recently, we also have a huge Somali and Liberian population, as well as Russian and many Bosnian Serbians who came over after their civil war. So we have a mix of a lot of people here in the end, which is interesting because we have people that are not always, speaking English as their native language. So from a care delivery perspective, we have a lot of, interpreters, and we work with that a lot to serve the patients as best we can. So, but yeah, so it's a little bit of a mix, but certainly we're, primarily an upper Midwestern kind of Caucasian heritage group.
That's great. Now it's helpful to get our bearings on who it is that you're serving. And I have a smile on my face when I'm thinking about Minnesota, and it does feel like people from the Midwest in particular, and perhaps even Minnesota, just seem to have a great outlook on life. Of course, not immune to depression and anxiety during this time or likely any other time, right? And the cold weather probably plays into that. But it does. If
you were here right now, there's a lot of people that are getting very surly and agitated with all the weather, the snow we've been having. We've had record snows and cold temperatures, so people are kind of getting done with the winter at this point.
Yeah, I'm sure. Great. We will move on to the next slide. I'm going to actually remind folks or share with folks, I haven't shared it yet, that you're welcome to ask questions anytime on the GoToWebinar control panel in that question feature. We will pause at certain points and look down at those questions. So feel free to ask them at any point. Let's move on to the next slide. I wanted to start, though, with a couple questions about how you got started before we move into the student program. Yeah, tell us, why did maternal mental health come up? Who were your champions? How did it all come to be?
Yeah, so we started this process back in 2010. At the time, it was started by in behavioral health, the chair of our department. She has since moved on and lives in Illinois now. But she had the forethought and sort of insight to know that maternal mental health was something that there was a gap, and that it was going to become more of an important thing. We also, within our behavioral health here at Park, we serve both adults and child and adolescents. So we have that advantage of being able to see what happens when, children experience, traumatic events and ACEs and, parental depression early on and that sort of thing. So we get to sort of see both ends of the development. So back in 2010, we sort of gathered up our stakeholders. And at the time, those stakeholders were the chairs of the departments that you see on the screen now. So we had the chair of pediatrics, family medicine, OBGYN, obviously behavioral health, and those were the sort of people that were getting on board with this. We were really lucky in that it did not take us a ton of convincing to convince our primary care, our pediatric and OB colleagues that this was important. Because ultimately, in a screening process, what we're asking them to do is do more. Another screening form, another 5 minutes out of a very tight 20-minute office visit. And so those leaders were on board with this. They understood the value of behavioral health and the value of treating specifically moms as early as we could for ultimately good outcomes for mom, for the kids, and for families. So we sort of really do view it as a global thing. So that's what we did in 2010. And then over the course of the next sort of year and a half, 2 years, we sort of slowly rolled out and piloted this. So we opted to use the Edinburgh Postnatal Depression Scale versus as opposed to something like the PHQ-9. I like the EPDS better because those questions really are more specifically designed for maternal depression and anxiety, as opposed to the EPDS is much more vague. It's more sort of typical depression. It has questions about sleep and fatigue, which I think are really easy false positives to come up with when you have a 1-month-old. So we slowly started rolling out the EPDS. We started first with in OBGYN with our biggest OBGYN practice, which happens to be here in St. Louis Park, where we were piloting the process and the workflow and how is the EPDS going to be handed out and what is the rooming nurse going to do and all of that. And once we fine-tuned that, we expanded that then to all of OBGYN. We have multiple clinics, like I said, spread out over the metropolitan area. And then after we're doing OB and the midwives, we rolled out our pediatric one second. We decided to do that first because, and something that we continue to sort of learn along the way is doing screenings in OB are easier because mom is the identified patient. And so it's easy, it's in her chart and all of that. When we do things at the pediatric visit, baby is the identified patient. And so things are a little bit more complicated. Also, we were asking pediatricians now to screen adults and sort of think of adult mental health. And so there was more training and buy-in that we needed from the pediatric providers, which we got. They just needed support and sort of understanding. So what we would say is sort of by the winter of 2011, we were doing universal screening, which means we were doing this protocol across OB and pediatrics. So.
Great. I'm going to pause there. And again, if folks want to ask questions, feel free to jump in. There were a couple of things that you said that I thought I would hit on again, Dr. Mauren. So the first thing that you were talking about the screening tool, and I think you might have flip-flopped. You said you use EPDS, and then I think you might have. So just to clarify, you use the EPDS.
There was a glitch. Yeah. I'm sorry. Go ahead.
That you use that tool, you prefer it for a variety of reasons because of sleep. And then, we like to point out, or from what we gather, would love your thoughts on this, is it also has a question about anxiety. So you may be picking up on anxiety, which we know often is the precursor to depression. Yep. Do you want to touch on that at all?
Yeah, it's exactly that. The EPDS intentionally, when it was being developed, almost 30 years ago now, took out those sort of physiological questions around sleep and fatigue because everybody's tired. And on the PHQ-9, if you put the highest score for that, it's a 3, you immediately have a 6 on those 2 items. And so the skew on that, I think, ultimately makes that tool less efficient and effective for this particular population. But yeah, and then the other advantage I think that the EPDS has is that there are basically there's 3 questions that get at anxiety. So someone could get kind of sort of zeros on all the depression questions, but could score really, really high on those anxiety questions. And I think that helps ultimately the clinician sort of tease that out and maybe start to ask some questions about what's going on for her. So I think the nuance of that is more helpful.
Thank you. And thanks for pointing out that there are actually 3 questions that might get at anxiety. That's a good reminder for all of us. I want to stop for just a little bit and ask you, at first, just to remind the folks who are maybe in community-based settings, so aren't really thinking about these large systems. When you say chair, describe,
sure.
You mean like the lead MD, and usually they're like based in the hospital, but have oversight for the full OB or pediatric program. Is that right? Can you clarify that just a little bit?
Yeah. Absolutely, yeah. So the chair in our system, and typically the chairs of departments are MDs. So the chair of behavioral health for us is a psychiatrist. It always has been. It always will be. And so the chair of pediatrics would be a pediatrician by training, OB, et cetera. And so in our system, depending on how it's set up, that person could have oversight over both the hospital inpatient portion as well as outpatient clinics. So like our pediatrician, our pediatric chair would oversee both the doctors who round in the hospital in our birth center, as well as the outpatient doctors in the clinic. So those are pretty big jobs.
Yeah, indeed. Very big
And
jobs.
They usually see patients still too. So.
tell us a little bit about, I think we got a sense now for sort of pediatrics. We started with the pilot with OB, including nurse midwives, and then rolled it out to pediatrics, and we see the time frames on the screen. I don't know if you touched yet on this special care nursery, and this might be the name of this NICU.
Yeah. So what we have, and I'll say that the timeline that you guys are seeing on the screen right now is something that has sort of developed over time. We've tweaked the time. We've added some times. We used to do EPDS at discharge from our hospital, from our birth center. We stopped doing that because we were getting all these false positives because you just had a baby 36 hours ago. So some of that we've tweaked over the 8 years we've been doing this. Our special care nursery, so at our main hospital, which is Methodist Hospital, it's our largest birth center. So we have a special care nursery that is equipped to care for babies that are at least 32 weeks old when they're born. And then there are parameters around what conditions we can treat. So if a baby even is 34 weeks but is in a great deal of distress and has a lot of medical complications, we would have to transport them to our children's hospital, which is by ambulance probably 15 minutes away, 20 minutes away. So our special care nursery, those babies tend to be there anywhere between a couple days to maybe a week. Typically, they're just needing a little help with some lung development and things like that. So it's higher intensity treatment, but not like a NICU. And so what we did with that was knowing that having a baby with medical complications after birth is such a high risk factor for postpartum depression and anxiety, we sort of created this extra screening protocol for those moms and dads. We'll screen both dads in that setting. So we do it once a week. We do it on Mondays while the baby is admitted. So usually a mom will get screened once or twice in that time frame.
That's really helpful. And I think another important piece of information you just shared is that you had started out screening post-delivery while mom was inpatient, and now don't do that. And there does seem to be a lot of energy in hospital staff for wanting to do more to help moms, and that's kind of the first thing people think of. So I think that's a really important point.
Yeah. So what we have now for that, we have in our hospital setting between the the rounding OB, the rounding pediatrician, we also have psych consult in our hospital. So if they are concerned about a mom, we tell them, hey, screen her or talk to her kind of like outside of the protocol. So it's not that they can't do it or that they don't have the resources. We just don't do it routinely because we were just getting so many women that were scoring high that weren't really sad or anxious. It was just the newness of all this and the healing process and all that jazz. So.
Yeah. Okay, great. Now that's helpful. So if there's an obvious problem or they feel concerned, they can still screen. It's just not part of your formal protocol.
Correct. Yeah. Like the required.
Yeah. Got it. That's really helpful. And I'm going to make sure that the hospitals here in California that now have an obligation to do some maternal mental health work get to hear this webinar and hear that part in particular and understand what's going on there. Let me ask you one more question before we move off hospitals.
Okay.
Have you found that there are any other types of programs that have been helpful for hospitals in your system to create? And let me, perhaps a support group for special care nurse or NICU moms, or education and birth classes if you're still having birth classes, for example. Anything along those lines that you're aware of that you would want to share?
Yeah, so those sort of resources, I would say, aren't owned by Park Nicollet. They tend to be more community resources. So we have an organization here in the Twin Cities. It's called AMA Parenting, who does all of our birth classes. And so they will have weekend seminars or a series of group around labor, around pain management, lactation. They do a new mama class that's like a 7-week class after your baby is born. So we will we have contracts with them, so we'll refer our patients that way. When it comes to sort of support for NICU moms or even women that have babies that are still needing extra support, That lives in Children's Hospital. So again, we would be sort of utilizing our patients. Our mom may be a patient of us, but their baby is a patient at Children's. So we would be kind of coordinating care and support services that way.
Great. I think that's really helpful. And if you don't mind, I know that we, when you came to California last month and had a chance to be a part of the larger discussion, big focus at the 2020 Mom Forum was around birth trauma. Mm-hmm. And so while we're on the hospital topic, Dr. Mauren, I think it's nice to hear a little bit about what your system is doing to attempt to prevent birth trauma. Mm-hmm. We've talked about how your hospital system is doing fantastic work around controls to prevent maternal death during delivery, which we all are following the news and hearing that our rates are still increasing in the U.S. Yeah. And these to be preventable. Do you want to touch on any of that before we move on to the next slide?
Yeah, I'm happy to. So in that very first slide, you saw that across our health system, all of our affiliated hospitals, we do about 6,000 births a year. So in 2017 and then in 2018, we've only had one maternal death in 12,000 births. That one death was in 2017, so we had 0 in 2018. Yeah, and the things we do are a lot of the sort of best practices around training and doing emergency drills. Our hospital staff, nurses, doctors, are constantly going through training where they're doing symposium and we have a sim center where people can go and practice skills without, sort of patient danger and those sort of things. In our hospital, our main hospital, Methodist, we also have a team of MDs that are on at all times. We have 2 OBs and or a laborist. We have a midwife, a nurse practitioner, a pediatrician, and an anesthesiologist on call at all times. We've developed special protocols around hemorrhage and things like that. So, and we work in a big system like ours. We have the Epic medical record, like many systems do. So we've built tools into Epic around if a hemorrhage is happening. In a few clicks, everything goes into place and things get done in a very urgent fashion. So we've done a lot around that. We've also done some work around transfer of care communication, which is one of the highest times in inpatient for any patient to have a medical error happen or a medical error of any type. So we've talked about like improving that and best practices and using our electronic medical record to its fullest capacity for that. And we've also looked into, as our bigger organization, we do a lot on healthcare disparities because we have such a huge population. We have so many data points to work with that. So we've done lots of healthcare disparity work on general things like asthma and colorectal screenings, but we also have looked at like cardiovascular disease, which is a huge risk factor for preeclampsia and things like that. So it's the being in a big system like this affords us these resources to improve care a lot. So it's great.
Absolutely. It does make the case for a big system when you hear about being able to put these protocols in place and have a great support system, which we know all those deliver, right? And hospitals want and really look to these kinds of protocols to get their system be small. Yeah.
Yeah. And two other things to sort of highlight around things that we do to sort of support mom's health and that sort of thing is so in our Methodist hospital, which is our main hospital, so we have obviously an ER department and then our birth center. And so if a mom presents to the ER for any reason whatsoever, even if it might not be a direct pregnancy related concern, once she is 20 weeks gestation or more, she's not seen in the ER. She's actually sent upstairs to labor and delivery. So we have then our OB specialists are the ones that are monitoring her and such. So I think that helps having those specialized eyes in those dangerous times. And then we also have what we call our Healthy Beginnings program, which is across our system, and it's around support and resource management for moms who have either a chemical health history or at their initial prenatal visit test positive for alcohol, drugs, et cetera. And so then we have supports and resources within that to help her manage that and ultimately to use less or hopefully zero, obviously, substances so that pregnancy can be healthy, which then lowers our risk when she's in labor and lowers that baby's risk, obviously. So.
Great. Really helpful. Again, if folks have questions, I think these hospital-based questions are really interesting to tease out, and you're obviously doing a lot of great work in this space. I wanted to ask two more questions. One is, we mentioned that hospitals tend to want to screen right after delivery, but we also are hearing and really pushing for, and we'd like your thoughts on this, ER departments to be ready for mothers who may be suffering from a maternal mental health disorder and suicidal and coming to the ER. What protocols have you been able to put in place, or are you looking at doing at Park Nicollet?
Yeah, so we've done some training with not the ER docs, but more the ER triage nurses, because they're the ones laying eyes on them. And so especially around, though it is a rare condition, it's what would bring you to the ER, like postpartum psychosis, because that is a condition that can often be lost or missed, and then that woman sent home when she should not have been. So we've done some work around that. In our system, our Methodist hospital doesn't have inpatient psych beds. In our system, we have another hospital that does. So if someone needed inpatient, they'd be getting transported to that. It's called Regions, is that hospital. But we've done work around having, if a mom does get admitted to our hospital for mental health stuff because there is no bed, we have a psychiatric consult liaison service that rounds in the hospital that is part of behavioral health. And one of the, there's three main docs that rotate there, and one of those docs is one of our sort of reproductive psychiatry experts. So she'll be the one that will see moms either if they've been admitted from the ER to like a general inpatient floor, or if through our birth center. So we have some specialized psychiatry training there.
Yep, great. Really helpful. There also seems to be this movement to have specialized inpatient programs for mothers around maternal mental health. Has that been something that Park Nicollet has considered, or has it just not been necessary? Is there a separate wing, if you will, of the psych floor? Yeah.
So we don't, in the Twin Cities, we don't have any specialized like inpatient services, which would be great. And if one of the hospitals that has inpatient beds develops that, I would be super thrilled. But what we do have is 3 intensive outpatient programs for postpartum depression and anxiety, which is great. We were, the first one was developed a handful of years ago. At the time, it was only the 3rd in the country. So we were so thrilled and lucky to have that. And then in the sort of subsequent years, 2 other groups that are outside of Park, so they're independent mental health clinics, have developed IOPs for moms. So
great. Yep. So hopefully preventing need for an inpatient stay.
Correct.
Yep.
Yeah.
Or step down, right? If someone's released from an inpatient stay, where do they go to kind of get reacclimated and stable?
Yeah.
Great.
And for us, all 3 of those programs here have the structure where, mom comes there for, basically from 9 to 3 during the day, and then she can bring her baby with. So she can bring her baby to group and to sessions, but if baby needs to take a nap or mom just needs a break, there's childcare within the program. So, which is, when you're developing that program, you have to have that. I mean, it's just a non-negotiable. You have to manage the childcare problem for sure.
Great. Good. Well, let's move on. And again, encouraging anyone who has questions. I have so many, and you may have some too. Please feel free to use that chat or that question feature in the GoToWebinar control panel. So we're going to move on to what your primary care or OBGYN/pediatric workflow looks like.
Yeah.
So walk us through the slide.
Yeah. So generally speaking, the actual like step-by-step is the same whether mom is at OB, pediatrics, family medicine, etc. So we do, the EPDS is given to the mom at check-in. In our system, the need for the EPDS is attached to the office visit, the type of office visit. So when mom is checking in, an alert fires for our we call them frontline, is our administrative staff, fires for them to know that they need to print a label and hand her the EPDS. So then mom then has the ability to fill that out while she's waiting in the lobby. or if she's been roomed and she can finish it up then, our rooming nurse would come in and confirm a couple things. So on our EPDS, it's the same structurally that's in the official EPDS manual. On the top, we've customized it a little bit around getting mom's contact information. So we can put a normal label on there, but we always ask that the rooming nurse confirms that she has handwritten in her name, her birthday, and her phone number. And the reason we do that is just in case a label doesn't get on there for whatever reason. We still have her name and her birthday, and we can look up her chart. But we specifically ask for that phone number too, because we want to be sensitive that she may want to give us a phone number to call her that is different than what's in her chart. Or she may not want something to have a voicemail left on it just for her privacy or whatever may be happening in her home life. So when we always ask for those three pieces of information. The LPN or the rooming nurse will do the scoring, and in OBGYN that gets entered right into mom's chart. Right now we're working, on a side note here, we're working on developing some EPIC tools that will allow pediatric EPDSs when they're administered in pediatrics to get sort of funneled electronically to mom's chart, just as a time saver and that kind of thing, and so that all of her information can be sort of consistently that way. So the rooming nurse scores it, and then in the transition between rooming nurse and having the provider, the clinician come in, they'll share the information. So then the OB or the pediatrician, whoever, will have that EPDS in front of them to be able to talk through answers or maybe see the high scores and ask specifically about those ones that she got 2s and 3s on. The clinician will then document in the chart the plan. And in pediatrics, so this is a long time coming. There's many discussions around this. We had lots of conversations around what do we document when it's the baby's chart. So in the mom's chart, when it's OB or pediatric, or midwifery, that clinician will document as she sees fit, or they see fit. What are the symptoms? What is the plan? What is the mom's experience, right? It's mom's chart. But we wanted to be very careful around putting too much or detail of mom's information into baby's chart. A, it's not mom's chart. And B, anything in that baby's chart would be discoverable if there were legal things. So we sort of projected down the future of like, what would we want if this family ultimately leads to divorce, and then that way dad or the other parent would have access to that child's chart because they are a legal guardian of that. And so we were just sort of projecting forward and easily seeing that scenario where in a divorce, the other parent could use an EPDS score against a mom in a custody battle. Kind of like the whole, see, she's crazy, she had postpartum depression. So we were very cautious around that. So what we came up with was, so we have to document something in the pediatric chart because in the state of Minnesota, pediatricians can get paid. It is a billable service to do the EPDS. So we had to document something. So we had a sentence that it's one of two sentences. It was EPDS was administered and no follow-up was done, means it's a negative score. So that was our code for she had a score of under 10. And if it said EPDS was administered and appropriate follow-up done, that was sort of code for a positive score. It doesn't say anything about her symptoms, the severity, that sort of thing, but it was enough to sort of satisfy for billing and kind of gave that sort of positive negative vibe. So that's what the clinician would do in pediatrics. Like I said, in OB, when mom is the patient, they would document as they would see fit. And then at the end of the day, all of those EPDSs are faxed to us. Right now, we live in a paper copy world still, so they get sent to behavioral health. When we get that new EPIC tool up and running, this will be done electronically, and instead of faxes, the scores will come to a queue for one of our care coordinators. So that will be great and save some trees, and we won't have to worry about the risk of faxes not going through and all of that jazz. So that's what happens in the primary care world.
Great, good. I'm going to pause and see if folks want to ask questions about this workflow. It sounds really good, and we get the sort of the fax issue and things getting missed. what I would like to pause on, I think we might, again, don't be shy. If you've got a question, we want to hear about it. Can you talk to us a little bit about, we'll get to your behavioral health sort of staffing and workflow in just a moment, but maybe this is a good segue to care coordinators and just how important that role has been in rolling out a screening process. And let me go ahead and move on to the next slide.
Yeah. So when we started this process and started doing those pilot projects in 2010, 2011, we did not have the care coordinator piece in place. The physician or the NP would be doing the screening in that office visit, and then they would be in charge of managing it with their nurse or whoever, right? So if a referral had to be made or a resource had to be made or something like that, that's how it worked. And after we started doing it, what we realized is that was, again, pretty much okay for OB. They were, again, used to working with adult patients. Usually these were patients that they'd seen through their pregnancy, so there was some familiarity. But we ran into some gaps that were happening in our pediatric visits. And if, a couple of slides ago, when you look at our protocol of when moms are screened, the vast majority of our screens occur at well child visits. So we added, after 2 years, we added the care coordinator position, ultimately to support everybody, but really to support pediatrics, so that they could, we always encourage our pediatricians, if she is positive or she's not doing well, have a conversation with her and support her so you can understand what's happening. But then we sort of thought, well, why would we be asking our pediatricians, our OBs who are not behavioral health specialists to be behavioral health specialists then? So bring it to us so that we can do the right assessment and get the moms connected to what they need. So that care coordinator position becomes really vital in terms of being able to support pediatricians. They are far more willing and open to doing a screening if they know that there's the behavioral health support on the background. And ultimately, it means too that mom then can really get what she needs. We're not then with a care coordinator encumbered by a 20-minute office visit where they also have to do, an ADOS and do immunizations and all of that stuff. So the care of mom was much better. And one thing in particular that we found made a huge difference was, so in those first 2 years, if a woman was in an office visit with her OB and she was not doing well and she said, yes, I would like a referral to OBGYN, or to behavioral health, or the doctor was like, hey, I really want you to go see a therapist. So those appointments were often being made in the office visit, which is great. It sounds great. But what was happening was that there was an incredibly high no-show rate for those type of appointments, which I've always hypothesized as the mom having been a little bit on the fence about wanting to go to therapy. That can be sort of scary, but wanting to follow the instructions of her OBGYN, her trusted doctor, who's looking her right in the face. How are you going to say no? But so they would eventually just no-show an appointment. But then when we got our care coordinator involved, she may still that appointment might get made for her. And then we come back, 2 days later, give her a call and ask about how other things are going, ask if they have any questions about that initial appointment in behavioral health, remind her of the appointment time. And then as a result of that, our no-show rate for those appointments went down to nil, basically. It went from 25% down to 5%. So
really?
Wow. Yeah, absolutely. That was my hypothesis. And so when that data came through and it happened, I was obviously pleased. So I think it's partly the second touch, the reassurance, the explanation of what to expect, because I think people think that what therapy and psychiatry is what they've seen on TV. And so that seems scary and weird. So being able to do some of that education and reassurance, and also just reminding, right? You've got a newborn or you've got a 3-month-old. And even if you have the intention to get that appointment, to get to that appointment, you may forget. And so just that reminder helps as well. So the care coordinator has been a huge, huge asset, both for us in behavioral health in terms of getting her what she needs, as well as our primary care colleagues.
Really helpful. And let me pause on that point for just a moment. And again, encouraging everyone to ask questions as well if you've got them. So we hit on it earlier that Park Nicollet, you sort of mentioned these sort of 3 branches, but it is also a closed, what we would call a staff model health plan, where the doctors are employed by Park Nicollet, right? Not contracted with different different health systems, etc. So what I think about around care coordination, if we're not in a closed system, so if we're talking about, OBGYN practice that's perhaps large enough to think about a screening protocol, one of the struggles I think that patients and OBs and others, pediatricians, those who screen, run into is sort of who's in my behavioral network? Is it covered by insurance? And so is there anything that you, obviously it's really helpful to have behavioral health and OB kind of under one roof, but would you have any advice for folks around, sort of the added need for care coordination when things are even more complex? Not to put you on the spot there, but yeah.
No, I think that if we're envisioning it like where it's a freestanding OBGYN practice who doesn't have behavioral health, so any referral they make has to be to an outside clinician in private practice, behavioral health clinic, etc. To me, that would only quadruple the need for that OB practice to have a care coordinator, preferably someone who is a licensed social worker who would kind of know how to navigate the system, and so that that they could be the ones that help patients find those providers. It's one thing to have a therapist in network. That's great. Obviously, people want to do that for the cost factor of it, but not every therapist is going to be competent to treat perinatal mood and anxiety disorders. So having one person who can have their sort of thumb on the pulse of in my community locally, who are the vetted clinicians, who have the training, who has the right credentials, those sort of things, I think that would make a huge difference, because moms with a newborn or a 1-month-old at home don't have time to go look up the internet, right? And search for, who are the therapists in my network, and then what do they specialize in, and all of that jazz. So I think that hand-holding component that could be done by the medical side of things into behavioral health would make a ton of difference.
Right. Yeah, that's what I think all of us, especially me, we're thinking. But thank you for that confirmation, just based off of your experience. Great. Yeah. So anything else? Do you want to talk a little bit about the other boxes here, the letter and general resources, things like that?
Yeah. So once those EPDSs get sent to behavioral health, that's kind of where that upper left-hand corner box starts. And then we've got two workflows. Either the score is positive or negative. A positive for us, we decided to take the most conservative approach. So we use a total score of 10 or higher. Some places will use a 12 or a 13. We decided to use 10, or any non-negative answer on number 10, which is the safety sort of suicide question. So someone could have a total score of 8, but if they put a 1 for the number 10, that sort of trips the switch and they become positive. So I'll do the negatives first. That's the more straightforward one. So we get all of those negatives. And ultimately what we're doing is we're just keeping a tally of where they came from, what clinic they came from, and then we send them off to be put into mom's chart. Very simple. The reason we keep that tally is so that we can understand volume, number one. And also I can tell from how many EPDSs we get from a certain clinic whether they're doing them or not. Because I know how many pediatricians are there, and so I can extrapolate how many EPDSs we should be getting. So it's also a way for me to sort of monitor that the model is being followed. Generally speaking, across our entire system, we have about an 85% administration rate. So 85% of the time when the EPDS is supposed to be done, it is done. That 15% could be on the occasion that a frontline person forgot, or more that the mom has declined the assessment. So most of the time moms take it, which is also great for us. So that's the negative. On the positive score, so all those positives come, and those then come to the care coordinator here in behavioral health. And we have a sort of a decision tree around how we contact her. So generally speaking, the gold standard one we use is we try to contact her 2 times via phone. If the EPDS was given on a Monday, usually we'll try to call her Tuesday. Not the same day. She probably just had a doctor's appointment. Who knows if she's home yet? We don't want to inundate her. So we'd call her on a Tuesday, leave a message if we don't get a hold of her, and then call her again 2 to 3 days later. So we try to do it quick, but not, again, back to back, because we don't want to be annoying to her. So If we do get a hold of her, then you can see that big box in the lower right-hand corner is sort of what our care coordinators are doing. A very basic sort of biopsychosocial triage assessment. What are her needs? Social support. How is feeding going? How is she adjusting to motherhood? Does she have social supports? Are there any other sort of life situations where she might need resources for? And then again, sort of looking at sort of safety for both her and baby, if that's a concern. Based on that phone call, that triage assessment, our care coordinator would offer resources. So those could be other resources within Park Nicollet, like lactation. We could get her hooked up with one of our lactation consultants for an appointment. It could be community or county resources, or it could be a warm handoff to behavioral health intake scheduling to schedule with therapy or psychiatry. So those are kind of the three main sort of areas of resources that we provide. If after 2 contacts we don't get a hold of her, we have a very basic letter that says, hey, in a recent visit, you filled out the Edinburgh Postnatal Depression Scale. Based on your score, it sounds like things might be hard right now. I'm here to help. Here's my phone number. So very basic. And then we have developed a little, like a trifold brochure that we call the Maternal Wellness Guide, which has resources, pregnancy, postpartum, around, again, some of those big community resources that we often refer to. It has our phone number in it. So sometimes the idea being that, like, hey, she may be not interested in therapy right now. Maybe she's hoping that these symptoms will kind of go away on their own, but we've got our phone number there. So if in 2 weeks she wants to call us, or in a month she wants to call us, we're kind of bringing the stuff to her. That was kind of overall the theme of the care coordinator role, was rather than making moms with new babies come to the medical world, she has to make the appointment. She has to call. We just flipped it around and said, well, let's bring it to her. So we will reach out by phone, by mail, so that she has what she needs, and just make that process a little bit easier for her. And then if we don't get a hold of her, we send that letter. In both cases, then the end result still is that the EPDS is put into mom's chart for documentation. So
really helpful. I had a couple follow-up questions. Again, I'm going to say it one last time. Feel free to ask questions to those of you on the line. I want to hear from you as well. Talk to us a little bit about, you talked about the biosocial assessment. Talk to us about who does the further assessment. I assume it's behavioral health to perhaps refine, is it anxiety? Is it depression? Is it PTSD? Is it general anxiety? Is it panic? Is there prior trauma? Is it bipolar disorder? Sort of, we know the importance of ruling out bipolar disorder before we treat with prescription drug treatments for depression. Can you talk a little bit about that secondary assessment or assessment?
Once they get, if they in that call with the care coordinator, if the patient then says, yes, I'm open to seeing a therapist or a psychiatrist, they'll do a warm phone handoff into intake, into our scheduling department. And then what we have, and I think that's probably maybe one of the next slides coming up, is in our reproductive mental health team within behavioral health, we have 9 therapists and 2 psychiatrists. There we go. Perfect. We have the master's level social worker, and then the 2 master's level, the social work interns, those are our care coordinators. So if the mom then gets an appointment with one of the psychiatrists or therapists, then they're going to come in and do a very typical behavioral health intake, where it's an hour long. We're going to get history, current symptoms, functioning, and all of that. So that deeper level nuance is done by the licensed professional.
Very good.
And then I'll just point out too that second bullet point around the protected appointment. So all the 2 psychiatrists, the 9 therapists, we have a special appointment type within EPIC for pregnant, postpartum, women who have just had a pregnancy loss, those things. So when a woman's calling into intake or being transferred to our intake and she reports, I just had a baby or I've just gone through a miscarriage, our intake department will automatically put women in those protected appointments so that we have good access for them, that they don't have to wait the typical, 8 to 12 weeks for a therapy visit. And so we also have what we call kind of regular, and then urgent. Urgent, for our definition, is the patient needs to be seen within 10 days. So
great. Good. Let's talk just a little bit before we wrap up, and you can share any sort of lessons learned. But I want to just touch on medication management for just a bit. And what I think your model does is, if it sounds like probably a range of treatment options may be presented, and there's sort of a treatment plan that a mom feels good about too. And it sounds like it almost always includes therapy, which is great. Do you empower or assist OBGYNs in learning how to prescribe, or do you not need to do that because it's a closed system and you've got psychiatry kind of readily available?
We absolutely actively want our OBGYNs and our midwives to prescribe antidepressants. To me, if you are working with women in reproductive age, you should understand how to do that. You should understand what is the safety, what are the risks, what are the benefits of SSRIs. I think to me that is a standard of practice for all OBs and midwives, NPs across the board. So in our system, the vast majority of our clinicians on those sides, in those departments, will prescribe. And so what we often see is a woman who has gone to her 6-week postpartum visit with her midwife. She's not doing well. They have a conversation, and the midwife actually starts her on the antidepressants, 100 milligrams of Zoloft, that kind of thing. And oftentimes that primary care doc will be the one that follows her with those meds. She might still then come to behavioral health for therapy, and then therapy will coordinate care back to the midwife. So with our psychiatrists, we do a combination of things. Certainly, if a woman has tried medications and has failed, we want her to see psychiatry. If she's really, really hesitant and needs to have a more one-on-one conversation with a psychiatrist and maybe with her partner to ask those questions, we would want that. We also want the more severe or potentially severe patients to come through psychiatry. So if we have a bipolar mom who has a history of bipolar disorder, when she gets pregnant, she's coming to psychiatry. Or she has a previous episode of really bad postpartum depression, and now she's pregnant again, and we need that management. So what we try to do is have our reproductive psychiatrists really seeing the most complicated, the moderate to severe complicated patients, and our mild, very straightforward patients, we would like primary care to manage them. And that's an access issue. We have psychiatry in-house, but there's never enough psychiatry. So.
Yep. Okay, great. No, that makes sense. There is never enough psychiatry there.
There's never enough psychiatry.
As a behavioral health board chair who knew that there was a need to address this, right? A gap and an ever-increasing need, right? The number of young women now that have pre-existing depression and anxiety, I think, even perpetuates that need more. So, excellent. One last question about we're going to get to data here too. We probably could have scheduled you for an hour and a half, Dr. Mauren. Love questions. But one quick question around benefit coverage, and you may not know the answer to this, but you sort of hit on biosocial factors and maybe support at home. And one of the things that we're starting to get questions about and inquiries about is whether health plans, and since Parklet has that arm, are starting to cover like baby nurses or doula care to support moms who are struggling at home and don't have support. Is that something that your system has explored or thought of yet?
Yeah. So our actual health plan will cover a doula for labor and delivery. It also will cover breast pumps and portions for some patients, a postpartum doula. That it's kind of part of their normal benefit. But our Minnesota Medicaid plan, that actually covers 100% a doula, a breast pump, after in-home services. So for our moms who have our state plans, they have even more coverage than the commercial plans. Our plans typically too in Minnesota, like again, it's going to differ from plan to plan, but our plans are also pretty consistently starting to cover acupuncture for pregnancy aches and pains and discomfort. Some of them will also cover like chiropractic care for pregnancy. Your hips get out of joint your pelvis gets out of joint. So some of that complementary medicine stuff is definitely coming into the market under insurance plans.
Great, no, that's helpful. Let's wrap up on the data summary slide, and any key points you want to share?
Yeah, so I mean, the sort of the big thing that people always notice with this is the volume. So what this means is that in 2018, we screened moms in our system over 19,000 times, which is just an astronomical amount to think about. When I think about that in a year total, you see it differently when the EPDSs get sent, 10 at a time through the fax. It's a different thing. As you can see, pretty consistently for the last 4 years, our positive rate is around 8%. That is about half of what epidemiological data would say, around, 17-ish% of moms having postpartum depression. I have always attributed that to the fact that the EPDS, though it is great, is what we would call very face valid, meaning that it's not sneaky. It's not like the MMPI where you don't know what we're asking. The questions are very clear what we're asking, and so it's really easy to fake good on that. We get a large portion of zeros. And in our little team, we always joke, like on any given day, like on my best day, I'm still like a 4, like there's some stress happening. And so I think that explains why those numbers don't maybe match up what the national expectation would be. Our percentage of contact is another interesting one, where percentage-wise, it has gone down over time. The actual raw number, as you can see, has gone up. I am attributing that to the fact that as the millennial generation is coming into parenthood, people don't talk on the phone anymore. People don't want to listen to a voicemail, and so that letter we send becomes even more important because it's another way to contact her. But I've been sort of mulling over in my mind, like, are there other ways for us to contact patients in a secure, private way, right? Like via text message. We have MyChart in our healthcare system, where we are approaching and trying to get a hold of women in ways that are more adaptable to kind of how communication is happening nowadays. So that's how I explain that. And I think there's some innovation and kind of growth room for us around using technology. So
that's great. And then just a quick question that came in on this one: percent of successful contact. That's some sort of live contact, it sounds like, or is there a different definition?
Yeah, successful contacts mean we got her on the phone.
Yeah.
Either we got her on the phone initially, or she called us back and we spoke on the phone.
Excellent. Well, let's wrap up with just any final words of wisdom as people start to think about developing these types of programs that you want to share, Dr. Mauren.
Yeah, I think that in retrospect, I think some of the things that we did right were, one, since we're such a big system, we rolled it out in stages so that we could adjust and correct errors before it got big, because it is far harder to put out a protocol and then have to retrain people than to be slow and get it finalized and then train on the initial thing. So I think that is one thing that we did well. And the other thing that has come back in spades for us was a very diligent and consistent getting on board the doctors, particularly the pediatricians. I had to go talk to so many pediatricians and go to department meetings and do dog and pony show to convince them why this matters. And when you have that buy-in, and it's great to have like the senior leaders and the senior management buy-in, and that can trickle down, but those clinicians that are actually in the office, they need to see this not as just something that I need to do to check a box because my boss told me to, but to pause and look at this and see and tell them how this will help with their patient care, whether their patient be the mom or their patient be the baby. And so I think being, again, very diligent and probably to the point of they probably got sick of me after a while because I was always being like, don't forget about this. I think that's something that laid the groundwork that makes our work now here 7-8 years later much easier.
Fantastic. Well, congratulations again on the award, the Innovation Award in Care. I'll just make one quick announcement that our submission process is open for our 2019 Innovation Awards. And so to the extent that any of you know about organizations that are doing great work around policy, care, or community awareness, we want to hear from them. And it's a very simple application process, as Dr. Mauren might be able to attest. And so again, really trying to lift up these best practices.
Yeah.
Well, thank you again, Dr. Mauren. We so appreciate you, and I expect that your webinar is going to be listened to quite frequently in the year to come. So thank you again, and congratulations.
Yeah, and thank you for acknowledging our program. And my email address is there, and I would welcome anybody to shoot me an email with any questions. I've since doing the Mom 2020, I've had a couple people reach out to me. I'm more than willing to set up a conference call and talk to individual clinics and systems about what we do here if people are trying to develop their own programs.
Fantastic. We appreciate that. Well, thanks, everybody. Yeah. And if you're not signed up yet to 2020 Moms e-newsletter, feel free to join us online on our website, and let's stay connected, all of us, as we do this really critically important work together. Thanks again, Dr. Mauren. Take care, everybody.
Thank you.